Question number one. You see a 65-year-old lady who is feeling unwell. She has had a productive cough for 3 days and is coughing up blue brown green sputum. She feels lethargic and feverish. Her past medical history includes rheumatoid arthritis, which she had had for over 30 years. She has been taking etanercept for 3 years and her disease is well controlled. On examination, her temperature is at 7.5, her respiratory rate is 17 breaths per minute, oxygen saturation is 98, and she has slight crackles in the base of her left lung. You prescribe a 7 days course of amoxicillin for lower respiratory tract infection and give her worsening advice. Which statement below is correct? RA is not associated with increased risk of infection. She can continue the etanercept with antibiotics. Patient with RA taking etanercept who develops infection need to stop the etanercept until the infection is cleared. Compared to the general population, her risk of TB is equivalent. A patient who is stable on etanercept needs blood monitoring every 3 months. So which one is the correct statement? I think the third one is correct. There was something about etanercept and antibiotics. Any option, doctors? RA is definitely associated with increased risk of infection. Second one, I'm not sure because I'm thinking third one is correct. Compared to general population, her risk of tuberculosis is equivalent, maybe increased. Patient who is stable on etanercept needs blood monitoring every 3 months. That I'm not sure. So let's see the answers. So the answer, this is correct. Patient with RA taking etanercept who develop an infection needs to stop etanercept until the infection is cleared. Let's see the other options also explanation. Patient taking RA etanercept who develops infection need to stop the etanercept until the infection is clear. RA is associated with approximate doubling of risk of infections. Chest infection and generalized sepsis are particular risks. Therefore, option 1 is wrong. Patient with RA taking etanercept to develop infection need to stop etanercept until infection is clear. Therefore, option 2 is wrong and option 3 is correct. There is an increased risk of TB or reactivation of latent TB during treatment with biological agents. So, etanercept is a biological agent and there is increased risk of TB. Therefore, option 4 is incorrect. The patient of biological therapy needs blood monitoring. Initially, they need a full blood count, urea, electrolytes, creatinine, and liver function tests 3 to 4 months after starting therapy, and then every 6 months once stable, unless clinically indicated. Therefore, option 5 is wrong. So, what they were saying, regular monitoring, right? Every 3 months. But then once they are stable, only after 6 months it's required. So, option 5 is wrong. Rheumatoid arthritis management. The management of rheumatoid arthritis has been revolutionized by the introduction of disease-modifying therapies in the past decade. Patients with evidence of joint inflammation should start a combination of disease-modifying drugs as soon as possible. Other important treatment includes analgesia, physiotherapy, and surgery. Initial treatment. NICE recommends DMARD monotherapy plus or minus a short course of bridging prednisolone. In the past, dual DMARD therapy was advocated as an initial step. Choices for initial DMARD therapy would be methotrexate. As the most widely used DMARD, monitoring of FBC and LFTs is essential due to the risk of myelosuppression and liver cirrhosis. Other important side effects include pneumonitis. So pulmonary fibrosis will also be there. So pneumonitis will be there. So you have to check that also. Sulfasalazine. Other DMARDs are sulfasalazine, leflunomide, hydroxychloroquine should only be considered for initial therapy if mild or palindromic disease is present. What is palindromic disease? Palindromic rheumatism is a form of inflammatory arthritis. It causes attacks or flare-ups of joint pain and inflammation that come and go. The joints look and feel like normal in between the attacks, and the attacks don't cause any lasting damage to the joints. So that is palindromic rheumatism. So hydroxychloroquine should be considered for initial therapy if mild disease or palindromic disease is there. That means comes and goes. Monitoring response to treatment. NICE recommends using a combination of CRP and disease activity using composite scores such as DAS28 to assess the response to treatment. Flares of RA are managed with corticosteroids, oral or intramuscular. TNF inhibitors. The current indication of TNF inhibitors is inadequate response to 2-DMARDs including methotrexate. So if there is inadequate response, then you give a TNF inhibitor. Etanercept, a recombinant human protein, acts as a decoy receptor for TNF-alpha. Subcutaneous administration can cause demyelination and risks include reactivation of tuberculosis. So it includes a risk of reactivation of tuberculosis. Etanercept. Infliximab, monoclonal antibody, binds to TNF-alpha and prevents it from binding with TNF receptors. Intravenous administration risks include reactivation of tuberculosis. Again, infliximab also causes reactivation of tuberculosis. Adalimumab, monoclonal antibody, subcutaneous administration is there. So these are the biologicals. Rituximab, anti-CD20 monoclonal antibody, results in B cell depletion. Give IG 1 gram intravenous infusions. Two 1 gram intravenous infusions are given 2 weeks apart. Infusion reactions are common with rituximab. Anti-CD20. Abatacept, fusion protein that modulates key signal required for activation of T lymphocytes, leads to decreased T cell proliferation and cytokine production. Given as an infusion, not currently recommended by NICE. It's not recommended by NICE then. So these are the drugs, and two of them, etanercept and infliximab, may cause reactivation of tuberculosis. And etanercept should be stopped when antibiotic course is going on. Acne vulgaris management: oral trimethoprim, oral flucloxacillin, topical benzoyl peroxide, topical zinc and erythromycin, oral isotretinoin, oral lamicycline, oral minocycline, oral erythromycin. For each one of the following questions, please select the correct answer from the options listed above. Should be avoided due to an increased risk of drug-induced lupus and hyperpigmentation. Option. These are the options.
Minocycline, I think.
Minocycline.
Most likely to affect the hepatic metabolism of other medications.
It will affect hepatic mechanism.
Hepatic
Metabolism
of other medications, huh?
Erythromycin.
Erythromycin.
Yeah, clarithromycin and erythromycin.
Yeah.
Prolonged treatment may depress hematopoiesis. Trimethoprim, I think, right? Trimethoprim, yesterday we have read causes.
Trimethoprim.
Something related to erythropoiesis, yes. Let's see the answers. Yeah, we are already all correct. So,
Good.
minocycline is correct, doctors. Increased risk of drug-induced lupus and hyperpigmentation. That's why nowadays we are not giving minocycline at all. Or most likely to affect the hepatic metabolism of other medications is erythromycin. Erythromycin is an inhibitor of P450 enzyme system. Prolonged treatment may depress hematopoiesis. Oral trimethoprim. For this reason, BNF recommends the specialist should make decisions about long-term treatment with trimethoprim. Acne vulgaris management is a common skin disorder which usually occurs in adolescence, typically affects the face, neck and upper trunk, is characterized by obstruction of the pilosebaceous follicles with keratin plaques, which results in comedones, inflammation and pustules. Acne may be classified into mild, moderate, severe. Mild means open and closed comedones with or without sparse inflammatory lesions. Moderate acne, widespread non-inflammatory lesions and numerous papules and pustules. Severe acne, extensive inflammatory lesions which may include nodules, pitting and scarring. So if pitting, scarring and nodules are there, it's severe. And non-inflammatory lesions, numerous papules and pustules, moderate. Sparse inflammatory lesions, open and closed comedones is mild. For people with mild to moderate acne, a 12-week course of topical combination therapy should be tried first. What will be in the topical combination? Fixed combination of topical adapalene or benzoyl peroxide. You should not give them alone because they will lead to resistance. So you give adapalene plus benzoyl peroxide. Fixed combination of tretinoin plus clindamycin. Fixed combination of benzoyl peroxide plus topical clindamycin. So these are three combinations. Topical benzoyl peroxide may be used as monotherapy if these options are contraindicated or the person wishes to avoid topical retinoid or an antibiotic. So only benzoyl peroxide can be given as monotherapy, but rest have to be given in combination, like antibiotic and tretinoin should be given in combinations. For people with moderate to severe acne, 12-week course of one of the following options: fixed combination of adapalene and benzoyl peroxide, fixed combination of topical tretinoin and clindamycin, fixed combination of topical adapalene with topical benzoyl peroxide plus either oral lamicycline or oral doxycycline. So these two are options are the same as mild to moderate, whereas in the third line you have adapalene plus benzoyl peroxide. Adapalene is a retinoid only. Uh, Retinoid only. It's a topical retinoid, adapalene, like tretinoin. So adapalene plus benzoyl peroxide plus oral lamicycline or doxycycline, topical azelaic acid plus oral lamicycline or doxycycline. Important points about oral antibiotic usage. Tetracycline should be avoided in pregnant, breastfeeding women and young children younger than 12 years of age. Erythromycin can be used for acne in pregnancy. Minocycline is now considered less appropriate due to possibility of irreversible pigmentation. Only continue a treatment option that includes antibiotic, topical or oral, for more than 6 months in exceptional circumstances. So 6 months, only 3 months you have to give antibiotic, but if at all 6 months you are giving, then only should be only in exceptional circumstances. Topical retinoid, if not contraindicated, or benzoyl peroxide should always be co-prescribed with oral antibiotics to reduce the risk of antibiotic resistance developing. So when you give me oral antibiotics for acne, you have to co-prescribe either topical retinoid or a benzoyl peroxide to prevent antibiotic resistance. Topical or oral antibiotics should not be given in combination. So you cannot give topical antibiotic plus an oral antibiotic for acne case at the same time. Gram-negative folliculitis may occur as a complication of long-term use of antibiotic. High-dose oral trimethoprim is ineffective if this occurs. So trimethoprim in acne is only given when you have a gram-negative folliculitis as a complication of long-term antibiotic use. That is the only indication for trimethoprim in acne. Combined oral contraceptive pills are an alternative to antibiotics in women. So you can give COCPs in women. As with antibiotics, they should be used in combination with topical agents. You should give topical agents. Dianette or cocyprindol is sometimes used as an as it has anti-androgen properties. However, it has increased risk of venous thromboembolism compared to other COCPs. Therefore, it should generally be used second line, only given 3 months, and women should be appropriately counseled about the risks. Oral isotretinoin, only under specialist supervision. Pregnancy is a contraindication to topical or oral retinoid treatment. So, and oral isotretinoin should only be initiated by a specialist. To reduce the risk of antibiotic resistance developing, the following should not be used to treat acne. Monotherapy with a topical antibiotic should always be combined with benzoyl peroxide or a retinoid. Monotherapy with oral antibiotic should always be combined with a topical retinol or benzoic acid. Benzoyl peroxide. Combination of topical antibiotic and oral antibiotic should not be used. Nice referral criteria. The following patient should be referred to a dermatologist. Patient with acne conglomerate acne. A rare severe form of acne found mostly in men that presents extensive inflammatory papules, suppurative nodules that may coalesce to form sinuses on the trunk. Patient with a nodulocystic acne. Referral should be considered in following scenarios: mild to moderate acne not responded to 2 completed courses of treatment. Moderate to severe acne has not responded to previous treatment that includes oral antibiotic. So if you have given an antibiotic and it has not responded to that, then you refer to a specialist. Acne with scarring, acne with persistent pigmentary changes, acne is causing or contributing to persistent psychological distress or a mental health disorder. You need to refer to a specialist. Where were we? Question number 5. A 6-7-year-old lady comes to see you complaining of dysuria and frequency. A past medical history includes hypertension, ischemic heart disease, and previous Clostridium difficile, chronic kidney disease stage 4. Her regular medications are ramipril, amlodipine, furosemide, aspirin. She reports allergies to statin and cotrimoxazole. Oh my god. Very complicated question. Her urine dipstick is positive for nitrates, leukocytes, and you diagnose UTI. Which would be the most appropriate antibiotic to start? So what is the antibiotic for UTI? Doxycycline? No. Trimethoprim? Yes. Efaclor? Yes. Amoxicillin? Yes. Nitrofurantoin? Yes. So first one is ruled out. So last 4 are there, and she is in chronic kidney disease stage 4, and also she has Clostridium difficile infection. So previously, and chronic disease stage 4, and ramipril, amlodipine, furosemide, and aspirin she is taking. and she has allergy to statins and cotrimoxazole.
So trimethoprim is ruled out again.
So trimethoprim is ruled out. She has allergy, right?
Yes.
Okay. So that is ruled out. Cefaclor, amoxicillin, nitrofurantoin.
If she has any chronic kidney disease stage 4, I think nitrofurantoin should not be given.
Yeah, that's true.
Yeah. So
It's
cefaclor and
contraindicated.
amoxicillin. Out of cefaclor and amoxicillin, she has a previous Clostridium difficile infection. So maybe cefaclor we will rule out.
Cefaclor. Go with cefaclor.
You want to go with cefaclor?
Contraindication for nitrofurantoin or trimethoprim.
Maybe amoxicillin also. Because cefaclor is broad spectrum, I think. And that's why, because she had a previous Clostridium difficile infection, maybe cefaclor also we should not use. Let's see the answer. Correct answer is amoxicillin. PNF currently recommends trimethoprim, nitrofurantoin as first line, with amoxicillin or cephalosporin as alternatives. So 1, 2, 3, 4. So doxycycline is ruled out. In this case, the patient is allergic to cotrimoxazole contain trimethoprim and sulfamethoxazole, so it is contraindicated. So trimethoprim is ruled out. She has CKD grade 4, that is 15 to 29 ml per minute, which is a contraindication to nitrofurantoin, and cephalosporins are known to predispose to Clostridium difficile. C for Clostridium difficile, C for cephalosporins. So cephalosporins are predisposing to Clostridium difficile. So in a patient with a history of Clostridium difficile, cefaclor would not be advised. Okay, doxycycline is not recommended in treatment of UTI. It leaves amoxicillin as the most appropriate antibiotic in this case. So again we are to antibiotic guidelines. We will just see UTI. Lower UTI, trimethoprim, nitrofurantoin. Alternative is amoxicillin, cephalosporin. No doxycycline here. Acute pyelonephritis, broad spectrum cephalosporin or quinolone. Acute prostatitis, quinolone or trimethoprim. Okay. A 23-year woman presents to the GP practice with 24-hour history of dysuria, visible hematuria, and general malaise. She is pyrexial. She has no past medical history and takes no regular medications. And examination reveals a soft abdomen, wide suprapubic tenderness. There's no renal angle tenderness and bowel sounds are normal. What is the correct management? She's just a normal woman. She's not pregnant. And only 24 hours history of dysuria, visible hematuria is there, and malaise is there. Why she has hematuria and malaise? And suprapubic tenderness is there. So what is the correct management? Admission for suspected pyelonephritis. Encourage hydration, review 24 to 48 hours. Oral antibiotics and midstream urine. Oral antibiotics, no investigation indicated. Urine dip and oral antibiotics. Since she has visible hematuria, urine culture will be required. So do we have any option with urine culture?
Oral antibiotic and the midstream
Midstream urine. Yeah.
midstream.
Okay.
Cystitis.
Yeah, cystitis she has.
Yeah.
Yeah, no investigation needed is wrong because we have to do urine culture. Dipstick will not help. Dipstick already told us that she will have hematuria and nitrates positive. But we need midstream urine for culture. No pyelonephritis because
No renal angle tenderness.
no renal angle tenderness and no constipation. Visible hematuria is there, that's why we have to do investigation. Send a MSU for all women with suspected UTI if associated with visible or non-visible hematuria, both. Okay. Where were we here? So this is general for urinary tract infection management, lower UTIs. Non-pregnant women, local antibiotic guidelines should be followed. NICE suggests trimethoprim or nitrofurantoin for 3 days only. Non-pregnant women, only 3 days. Send a urine culture if age more than 65 or visible or non-visible hematuria. So in our case, she had visible hematuria. So we will send for urine culture, that is midstream urine sample. Pregnant woman. Pregnant woman is symptomatic. Urine culture should be sent in all the cases. Should be treated with an antibiotic. First line is nitrofurantoin, should be avoided near term. Second line is amoxicillin or cephalexin. Trimethoprim is teratogenic in the first trimester, should be avoided during pregnancy. Asymptomatic bacteria in a pregnant woman. Urine culture should be performed routinely at the first antenatal visit. Clinical knowledge summaries recommend immediate antibiotic prescription of either nitrofurantoin, should be avoided near term, amoxicillin or cephalexin. This should be a 7 days course. So in a female pregnant woman with asymptomatic bacteria, the antibiotic should be 7 days course. Rationale of treating asymptomatic bacteria is significant risk of progression to pyelonephritis. Further, urine culture should be sent following completion of treatment as a test of cure. So test of cure is not urine dipstick, it's urine culture. MSU again. Men, an immediate antibiotic prescription should be offered for 7 days. So for men, you have to offer 7 days prescription. As with a non-pregnant woman, trimethoprim nitrofurantoin should be offered first line unless prostatitis is suspected. Urine culture should be sent in all the cases in men because it's not so common to have UTI in men, and if it is there, you have to send a urine culture before antibiotics are started. Nice. Referral to urology is not routinely required for men who have had one uncomplicated lower UTI. If they have had two, then you need to refer to a urology. Catheterized patient do not treat asymptomatic bacteria. If the patient is symptomatic, they should be treated with an antibiotic 7 days rather than a 3-day course. Consider removing or changing the catheter as soon as possible if it has been placed for longer than 7 days. Acute pyelonephritis, local antibiotic guidelines should be followed if the BNF currently recommends broad-spectrum cephalosporin or a quinolone for non-pregnant women for 10 to 14 days. Quinolone for non-pregnant women, cephalosporin for pregnant women, and 10 to 14 days is the course. Meera is a 27-week pregnant and travels to Peru to visit her mother who has terminal breast cancer. She is aware of the risk of Zika virus, uses an insect repellent containing DEET on all exposed areas. What further care does she need when she returns to the UK? Ultrasound of the fetus, amniocentesis, fetal cardiac monitoring, chorionic villus sampling, weekly fundal height measurements throughout the rest of the pregnancy. She is 27 weeks pregnant.
Amniocentesis.
Fetal cardiac monitoring.
Ultrasound of fetus.
Amniocentesis.
I think
What does Zika virus do to the baby? What does Zika virus do to the baby?
we will go with first option.
You need to do an ultrasound of the fetus when she comes back.
Yeah. First, we will do the ultrasound, and if it shows microcephaly, then we will go for the amniocentesis.
Good answer, doctor. There's a strong evidence that Zika virus leads to congenital microcephaly and other neurological developmental disorders of the fetus. National Travel Health Network and Center, NATNAC, have provided guidance to pregnant women traveling to Zika virus areas and state that pregnant women should postpone non-essential travel to areas with active Zika virus transmission until after pregnancy. Women should avoid becoming pregnant while traveling in an area with Zika virus transmission and for 8 weeks following return to home, whether they had symptoms of Zika virus infection or not. Pregnant women who have traveled to a Zika virus area are referred immediately to secondary care for regular ultrasound of the fetus throughout the pregnancy. Is recommended to look for microcephaly. Routine testing for Zika virus PCR via blood, urine, or amniotic fluid is not recommended for asymptomatic women. Those women who present with Zika virus symptoms during or 2 weeks after travel to Zika virus area should be tested for Zika virus PCR. So if they have symptoms, they should be tested for Zika virus PCR, and fetus is monitored through serial ultrasounds. If microcephaly is diagnosed on ultrasound, consideration can be given to amniocentesis to check for Zika PCR, however, only after weighing up the risks and benefits of amniocentesis. Chorionic venous sampling, fundal height measurements, cardiac monitoring are of no use in testing for Zika virus. Zika virus is a mosquito-borne infection caused by Zika. Zika is a mosquito-borne infection caused by Zika virus, member of the genus Flavivirus and family Flaviviridae. It is first isolated from a monkey in the Zika forest in Uganda. Transmission is usually via the bite of an infected Aedes mosquito. Although a small number of cases sexual transmission has been reported, there is increased evidence of transmission via placenta from mother to fetus. So, increased evidence of transmission from mother to fetus. Majority of people infected with Zika virus have no symptoms. For those who have symptoms, Zika virus tends to be cause a mild, short-lived 2 to 7 days febrile disease. Signs and symptoms suggestive of Zika virus infection may include fever, there will be a rash, arthralgia arthritis, conjunctivitis, myalgia, headache, retroorbital pain, pruritus. Almost all these symptoms are like dengue virus, except for the thrombocytopenia. Serious complications in adults are not common, although virus has been associated with GBS. Scientific consensus, however, has linked Zika with microcephaly and other congenital abnormalities, which has led to WHO to declare a public health emergency of international concern. Question number 8. A mother of a 6-week-old baby girl born at 32 weeks gestation asked for advice about immunization. What should happen regarding the first set of vaccines? Give a first set of vaccine at 3 months. So she is 6-week-old baby born at 32 weeks of gestation. So again comes to the question of vaccination, immunization and
Give age per
chronological age. So give
age
as
per
per normal timetable.
Normal timetable.
Okay, we should not see the answers. Two things are there. One is developmental milestones and one is vaccination. Developmental milestones will be as per the corrected age, corrected chronological age, whereas vaccination should be according to the normal time.
Normal.
I think that should be correct. Yeah, that's correct. So don't get confused. Don't waste your time reading the answers, options.
Good, good.
Whenever it
Okay.
comes to immunization, will be as per normal timetable. Okay, this is our immunization schedule. You should stick it on your wall and read it daily. There it is. Okay. So, BNF antibiotic guidelines: clarithromycin, flucloxacillin, ciprofloxacin, doxycycline, coamoxiclav, amoxicillin, phenoxymethylpenicillin, ampicillin, trimethoprim. I am not asking the answers. I am not showing the questions. Tell me, clarithromycin, where do you use? Clarithromycin, atypical pneumonia. Flucloxacillin, staphylococcus infection, wherever there is staphylococcus suspected, either after influenza, secondary bacterial infection after influenza, staphylococcus, flucloxacillin, or otitis externa. Ciprofloxacin, quinolones will be given in upper urinary tract infection.
Pyelonephritis.
Yeah, upper urinary tract infection. Doxycycline, chlamydia, also Lyme's disease. And one more for doxycycline is mm, acne vulgaris. Coamoxiclav will be given in. This is co, right? Double. Double will be given as peri.
in dental infections.
Okay.
Animal and human bite also.
Animal bite,
Comoxiclav.
yes. And then periorbital
Cellulitis also.
cellulitis. Periorbital cellulitis,
Cellulitis.
not
Near the
cellulitis.
nose and eye.
Yeah, periorbital and near the nose cellulitis. Cellulitis on the face because two, it is a strong one. Amoxicillin in cellulitis and urinary tract infections.
Otitis media.
Phenoxymethyl otitis media also.
Yeah.
Phenoxymethyl penicillin in otitis media, right? Otitis externa. Phenoxymethyl penicillin is for sinusitis.
Sinusitis and throat
Yeah.
infection.
Ampicillin. Where do you give ampicillin? Ampicillin, I think, in meningitis. Trimethoprim. Just now we read
UTI.
urinary tract infection. Okay.
UTI.
Okay. So erysipelas. What will be the
Flucloxacillin.
antibiotic of choice?
Flucloxacillin.
Flocloxacin. Flocloxacin.
Yeah. Flucloxacillin.
I think. And mastitis during breastfeeding also flucloxacin, I
Flucloxacillin.
think.
Yes.
Yeah, flucloxacillin.
Dental abscess.
Coamoxiclav.
Amoxicillin.
Amoxicillin.
Only plain
Amoxicillin.
amoxicillin.
Yeah. Plain amoxicillin. Yay! Correct answers. Clap for your.
Good. Clap for everyone.
Yeah. So, where were we confused? Exacerbations of chronic bronchitis, amoxicillin, tetracycline, clarithromycin. ACT. ACT. Amoxicillin, clarithromycin, tetracycline. In exacerbation of COPD, you have to ACT. Uncomplicated community acquired pneumonia, again amoxicillin. Pneumonia by atypical organisms, clarithromycin. Quinolone is for prostatitis, hospital acquired pneumonia. Within 5 days of admission is Comax. Yeah, again this is Comaxiclav. Okay.
Co-amoxicillin.
Yeah, or cefuroxime. More than 5 days, piperacillin, tazobactam, broad spectrum cephalosporin, or a quinolone. Conditions: lower UTI, trimethoprim, nitrofurantoin, amoxicillin, cephalosporin, pyelonephritis, broad spectrum cephalosporin or a quinolone, prostatitis, quinolone or trimethoprim. Skin conditions: impetigo, topical hydrogen peroxide, oral flucloxacillin or erythromycin if widespread. Cellulitis, again flucloxacillin. So cellulitis is not amoxicillin, is flucloxacillin. Okay. Cellulitis near the eyes and nose, coamoxiclav. Erysipelas is flucloxacillin. Previously it was phenoxymethyl penicillin, but now it is flucloxacillin. Animal or human bite, coamoxiclav. Mastitis, flucloxacillin. Throat infections. Throat infections, sinusitis. So ENT people will be using more of phenoxymethyl penicillin, or should be using actually, but they don't. Phenoxymethyl penicillin, and for sinusitis and throat infections, otitis media, amoxicillin, otitis externa, flucloxacillin, periapical periodontal abscess, only amoxicillin, gingivitis, necrotizing ulcerative, metronidazole. Genital system, gonorrhea, ceftriaxone intramuscular, chlamydia, doxycycline or azithromycin, pelvic inflammatory disease, ofloxacin, metronidazole, or ceftriaxone plus doxycycline plus oral metronidazole. So three organisms are there: gonorrhea, chlamydia. For gonorrhea, it's ceftriaxone; chlamydia, it is doxycycline, NPID, and oral metronidazole. Syphilis, benzathine, benzyl penicillin, or doxycycline or erythromycin. Bacterial vaginosis, topical metronidazole or topical clindamycin. GI conditions, clostriditis is difficult. C for clostriditis. No. Clostriditis is difficult. First episode, oral vancomycin. Second or subsequent episode, oral fidaxomicin. Campylobacter enteritis. C for Campylobacter. C for clarithromycin. Salmonella, non-typhoid salmonella, ciprofloxacin. Shigellosis, again ciprofloxacin. So ciprofloxacin is used for salmonella, shigella, UTIs, prostatitis, and where else is quinolone used? Here, hospital acquired pneumonia. Okay, we'll go to the next question. Question number 12. A 68-year-old woman presents with urinary frequency and dysuria for the past 3 days. She reports no vomiting or fevers and no back pain. She has background of osteoarthritis but no other significant medical conditions. On examination, she is mildly tender suprapubically and there is no renal anger tenderness. Her heart rate is 68, blood pressure is 134, tympanic temperature is 36.8. Temperature is fine. Urine analysis shows leukocytes 2 plus, nitrates positive, no hematuria. So leukocyte and nitrates are positive. According to current NICE guidelines, what is most appropriate management step? So she's 68 years old and no hematuria. So send a urine culture, commence 3-day course of nitrofurantoin immediately. Send a urine culture and commence 7-day course of nitrofurantoin immediately. Commence a 3-day course of nitrofurantoin immediately. Do not send a culture. Commence 7-day course of nitrofurantoin immediately. Do not send a culture. Send a urine culture but await results before commencing antibiotics. This is wrong, absolutely wrong. We should not await. We should start empirical antibiotics. Should we give a 7 days or a 3 days course? This is uncomplicated. No hematuria and no catheterization is there. So 3-day course is sufficient, right? And
3 days?
do we need to send a urine culture or not?
No,
No need?
because
I
no
think we
visible
can send.
traces
We have to
for
send urine culture.
No hematuria. That's true. And 68 years, 65 years, there was some clause with 65, right? What was that? I also forgot. So let's
No,
mark
we
option.
need to send.
Let's mark option one. No need. Send a urine culture. Commence a 3-day course of nitrofurantoin immediately. Why? MSC should be sent for all women over 65 years with a suspected urinary tract infection. So this was our option here. See, send a urine culture, non-pregnant woman, 3 days course of antibiotic, and a urine culture if age more than 65 years. Okay, or there is a hematuria. So she is 65 years old. We will send a urine culture. If there was a hematuria, we would send a urine culture. Okay. 13, question number 13. 73-year lady with indwelling catheter presents to surgery complaining of suprapubic pain, offensive smelling urine. She reports that she had only one urinary tract infection previously with severe symptoms. She appears to be significant discomfort day to day. What is the most appropriate course of action? Send a urine sample for culture. Hold off treating until result is back. No. Sample should be sent. Treat with 7-day course of antibiotic based on previous sensitivities and send another sample for culture today. I think this is right because
Mm,
she already had one
7 days.
UTI previously. So if there was a culture result then we would say, use sensitivity result. Then we will use that antibiotic for 7 days and send another sample for culture today. Not 3-day course because catheterized patient 7 days course. Refer to urology, no need. Topical antibiotics applied to the catheter, no need. Okay. So UTI in a catheterized patient, 7-day antibiotic instead of 3 days. And if there was a previous sensitivity report, you will use that antibiotic and another sample for culture you have to send today. 14 to 16, BNF antibiotic guidelines, erythromycin, trimethoprim, nitrofurantoin, amoxicillin, cephalosporin, quinolone, trimethoprim, vancomycin, amoxicillin or tetracycline or clarithromycin, phenoxymethyl penicillin plus flucloxacillin, amoxicillin, cephalosporin, erythromycin, doxycycline, broad spectrum cephalosporin or quinolone. Okay. Infective exacerbations of COPD. Doctors, ACT.
Act.
Where is our
E.
ACT?
E.
E, yeah. A.
E option.
Yes, ACT.
Acute pyelonephritis, cephalosporin,
Pyelonephritis, broad spectrum cephalosporin or quinolone.
quinolone.
Quinolones.
Manual.
Cellulitis, mild to moderate.
To moderate, amoxicillin,
Flucloxacillin.
fluclox.
Flucloxacillin.
Yeah, cellulitis is flucloxacillin. And face cellulitis is
Amoxicillin.
coamoxiclav.
Amoxicillin.
Coamoxiclav
No, Comax.
Oh,
for facial cellulitis. Right? Yeah. Cellulitis near the eyes or nose, coamoxiclav. Otherwise, flucloxacillin. Good job, doctors. All answers are correct. Question number 17. 21-year-old woman is 10 weeks pregnant. She sees her GP with dysuria. So she is a pregnant woman with dysuria and symptomatic. She has no other symptoms and no features of upper urinary tract infection. Systemically well. Urine dipstick shows leukocytes and nitrates. Urine sample is sent for culture. She started on a course of nitrofurantoin. GP follows up next week later and woman's symptoms have resolved. The urine culture has shown E. coli sensitive to nitrofurantoin. What should be the next management step? So 1 week later, so she has been given a 1 week course of antibiotic. That is sufficient. Culture was sent before, culture should be sent after because she is pregnant. Nothing wait and watch, no. Provide further prescription for nitrofurantoin, no. Repeat a urine culture as a test of cure.
Cure.
test of cure.
Okay, not urine dipstick, urine culture. Test of cure MSU should be present, sent in pregnant women for treatment. Treated women treated for a UTI. So
Good question. 18 to 20 we will cover.
yeah, so now you also like these questions, right? So,
Yes,
okay, the
yes.
same options, same antibiotic options. Let us see the questions, then if we will check the options. Huh? Gonorrhea,
I am
intramuscular, ceftriaxone.
IM ceftriaxone.
Yes. Extensive otitis externa. Extensive otitis externa.
Flucloxacillin.
Fluke.
Fluclox.
No, no,
Flucloxacillin.
this one is extensive, dear.
Extensive.
Amoxicillin.
Trimethoprim, this is for UTI. Quilonolone trimethoprim, doxycycline, metronidazole, ceftriaxone, doxycycline, amoxicillin, ciprofloxacin, Phenoxymethylpenicillin, flucloxacillin, amoxicillin, doxycycline, erythromycin, doxycycline, broad spectrum cephalosporin, trimethoprim. I think phenoxymethylpenicillin and flucloxacillin. But both are penicillins, no? Why we were giving combination?
I think only flucloxacillin.
Only G fluke
Only G.
Yeah.
Ah, okay. We will mark that. Okay. Pelvic inflammatory disease doctors. PI.
options of Indoctra, metronidazole, and ceftriaxone.
Yes. Just now we read. Ceftriaxone for covering gonococcal. Doxy for covering chlamydia. Metronidazole for other organisms. Correct.
Yes,
Exactly correct. Flucloxacin is for
yes.
extensive otitis externa also. Where was
But
it?
still, we will see in otitis externa option what they have given. We
Yeah,
will
because
check it.
ENT we will check. Okay.
Fluclox.
Otitis externa,
So,
flucloxacillin, erythromycin if penicillin allergic. They have
so here they
same.
have not mentioned like extensive or limited or like
Mm,
otitis externa yani flucloxacillin bas.
yeah, but there was something for like extensive otitis externa in diabetic patients, malignant otitis externa, and the antibiotic for malignant otitis externa was different. But anyways, whenever we come across it, we will see.
Okay.
32-year-old patient old presents to the GP at 37 weeks pregnancy with symptoms of urinary frequency and urgency. So she's pregnant at 37 weeks at term and frequency urgency. Systemical well describes good fetal movements, does not have vaginal bleeding, temperature is fine, heart rate is fine, respiratory rate is fine, and blood pressure is fine. Urine dipstick positive for leukocyte nitrate, negative for blood and ketones. Most appropriate action term pregnancy 37 weeks. Admit under obstetrics, send urine for microscopy, culture, sensitivity, treat based on the sensitivities, treat with 7 days of amoxicillin, treat with 7 days of nitrofurantoin, treat with 3 days of trimethoprim. 3 days is pulled out.
7 days of amoxicillin.
Even nitrofurantoin is ruled out because in last trimester contraindicated.
Yeah. So
Yeah.
we'll use amoxicillin.
7 days of amoxicillin.
Yeah.
Send urine for
Yes.
culture sensitivity and treat based on sensitivities. You cannot wait till you get sensitivity report, right? Admit to under hospital under obstetrics not required, right? Because her vitals are fine. I think this. Yeah. Absolutely correct, doctors. UTI in a pregnant woman in the third trimester use amoxicillin or cephalexin. Okay, because nitrofurantoin, why it is contraindicated? Trimethoprim. UTI in pregnancy should be treated for 7 days. Trimethoprim is contraindicated early pregnancy due to tetragenicity, but this is late pregnancy. However, treat with 7 days nitrofurantoin. Nitrofurantoin, why trimethoprim is wrong is 7 days you have to give, not 3 days. Trimethoprim can be given in late pregnancy. Treat with 7 days nitrofurantoin. Nitrofurantoin is contraindicated near term due to possibility of neonatal hemolysis. Which one of the following antibiotics is most likely to cause pseudomembranous colitis? So any broad spectrum antibiotics, cefaclor here or quinolones. Okay, pseudomembranous colitis or Clostridium difficile infection. Same as that cefaclor is the antibiotic implicated. Cephalosporins, not just clindamycin. Sorry, not ciprofloxacin. Not just clindamycin. Clindamycin, cephalosporins are strongly linked to C. difficile. Other risk factors for C. difficile infection is PPIs. Okay. It's a very important topic actually, and I'm really drained already. So I will try to read. Clostridium difficile is a gram-positive rod often encountered in hospital practice. It produces an exotoxin which causes intestinal damage leading to a syndrome called pseudomembranous colitis. C. difficile develops when normal gut flora is suppressed by broad-spectrum antibiotics. Clindamycin is historically associated with causing C. difficile, but the etiology is often evolved significantly over the past 10 years. Second and third generation cephalosporins are now leading cause of C. difficile infection. Other than the antibiotics, risk factors are PPIs. Pathophysiology. Anaerobic gram-positive spore-forming toxin-producing bacillus, transmission by fecal-oral route or ingestion of spores, release two exotoxins, toxin A, toxin B, that act on intestinal epithelial cells and inflammatory cells, resulting in colitis. Features. There will be diarrhea, abdominal pain, raised white cell count, and severe toxic megacolon may develop. If severe toxic megacolon may develop. So, this is a public health England severity scale used for determining the treatment. Mild, normal WCC count. Moderate, more than raised WCC count but it is less than 15,000, 3 to 5 loose stools per day. Severe, raised WCC count more than 15,000 or an acutely increased creatinine more than 50% above baseline or a temperature more than 38.5 or evidence of severe colitis, abdominal or radiological signs of toxic megacolon. Life threatening, there will be hypotension, partial or complete ileus, toxic megacolon, or CT evidence of severe disease. These are life threatening. Diagnosis is made by detecting Clostridium difficult toxin in the stool. This was also a question. Detecting Clostridium difficult toxin in the stool. C. difficult antigen positivity only shows exposure to the bacteria rather than current infection. So antigen is not diagnostic. Toxin is diagnostic. Management. Current antibiotic therapy should be reviewed and antibiotics stopped if possible. First episode of C. difficile, vancomycin for 10 days. Second line, pyroxamycin. Third line, vancomycin oral plus IV metronidazole. Recurrent episode. If recurrence occurs in 20% of the patients, increasing to 50% after the second episode. If recurrence occurs within 12 weeks of symptom resolution, oral pyroxamycin should be given. After 12 weeks of resolution, oral vancomycin or pyroxamycin should be given. Life-threatening C. difficile infection, oral vancomycin and IV metronidazole should be given. Specialist advice, surgery may be considered in case of life-threatening C. difficile infection when there is hypotension, toxic megacolon, ileus, and CT evidence of severe disease. So, other therapies. Bezlotoxumab is a monoclonal antibody which targets C. difficile toxin. NICE does not recommend its support. Currently support its use to prevent recurrence as it is not cost effective. Fecal microbiota transplant may be considered for patients who have 2 or more previous episodes. So this one was an X-ray of toxic megacolon. If you can see, doctors, look at the colon and how it is enlarged. On the abdominal film, note the loss of bubble wall architecture, tongue print consistent with colitis, CT form the same pen sheet enhanced by oral contrast. There is moderate flea fluid in the pelvis and peritoneum. Colon is edematous throughout with enhancing walls but of normal caliber. The sigmoid colon is smooth and featureless and small bowel, liver, spleen, kidneys, adrenals are normal. So where was the sigmoid colon? Is featureless. Okay, here. These are the kidneys. This is the bubble with enhancement and edema. Question number 23. Jason is a 66-year-old who is seeing you for advice on vaccination. She suffers from chronic kidney disease stage 1, hence is 66. Asthma for which he uses salbutamol. Asking if he is eligible for pneumococcal vaccine. What is the current advice? So CKD stage 1. Is he eligible? Asthmatic, he is not eligible because he is only using salbutamol and not any oral steroids. So first is wrong. No, he is not eligible as he does not have stage 4 chronic kidney disease. Yes, he is eligible as he has chronic kidney disease. Yes, he is eligible as he is over 65 years old. For pneumococcal vaccine, there is no 65 years criteria, right?
Chronic kidney disease.
No, he is not eligible as he is under the age of 70 years. Third one,
Third one, asplenia,
Yes, we will go
splenic
with third one.
dysfunction in chronic kidney disease.
I think it's over 65. Yeah, this is ages
Pneumococcal is there.
criteria.
Pneumococcal
Yeah, yeah.
65
There's a
years
age.
criteria is there for
Yes, yes.
both. Both is there.
65.
But why not chronic kidney disease? Because there is one thing like here. See, chronic kidney disease at stages 4 and 5 are only eligible for pneumococcal vaccine, not stage 1. Okay, so he will not qualify under this criteria because he is stage 1. But he is eligible because he is over 65. So over 65 applies to both influenza and pneumococcal vaccination. 25-year woman is diagnosed with UTI. She has a past history of epilepsy and is currently taking sodium valproate. Which one of the following antibiotics should be avoided if possible? So UTI, sodium valproate is an enzyme inhibitor, right? Enzyme inhibitor. So which antibiotic you should not give?
Cipro, Cipro, Ciproflox.
Yeah, ciprofloxacin. Okay. So let's go with ciprofloxacin. Ciprofloxacin lowers the seizure threshold. That's why it should not be given. Not about the enzyme inhibition. History of epilepsy is there. Ciprofloxacin reduces the seizure threshold. While many antibiotics can lower the seizure threshold, this effect is seen particularly with quinolones. The BNF advises quinolones should be used with caution in patients with history of epilepsy or conditions that predispose to seizures. Quinolones. Quinolones are a group of antibiotics which work by inhibiting DNA synthesis and are bactericidal in nature. Ciprofloxacin, levofloxacin, mechanism of action, inhibit topoisomerase 2, DNA gyrase, and topoisomerase 4. Mechanism of resistance, mutation in DNA gyrase, efflux pumps, which reduce intracellular concentration of quinolones. Adverse effects, lower the seizure threshold in patients with epilepsy, tendon damage, including rupture, risk is increased in patients taking steroids. Cartilage damage has been demonstrated in animal models. For this reason, quinolones are generally avoided, but not necessarily contraindicated in children. Lengthens the QT interval. Contraindications, quinolones should be generally avoided in women who are pregnant or breastfeeding, and avoid with G6PD, avoiding G6PD. Epilepsy, ciprofloxacin is contraindicated. 67-year-old man attends complaining of a 48-hour history of frequency of urination, dysuria, and lower abdominal pain. All of these are related to UTIs only. So we'll do quickly. 67 year, he's a man and he has UTI accompanied by occasional high fevers. Prior to this episode, he has not suffered any urinary problems. So this is the first attack. And he has no significant past medical history. Urine dipstick positive for leukocyte, nitrates for negative for blood and protein. What would be the most appropriate step? So any man, because UTI is not common, send for
Culture.
microscopy, culture sensitivity, not before starting treatment. Refer to urology under 2 weeks wait rule. Refer to medical team. No. Take a urethral swab to exclude STI. Prescribe oral antibiotics. I think prescribe oral antibiotics would be there. But why not culture? This is right, but before starting treatment, because he's having fever, right?
They had mentioned, sir, we should start oral antibiotics because it is the UTI is not so common in men.
Yeah, we will start, but culture also we have to do, no? That's what I'm thinking. Men with lower UTI should be treated with either thimerosal or nitrofurantoin unless prostatitis is suspected. That's okay. I'll go back again here. I'm just searching here.
Yes.
Immediate antibiotic prescription for 7 days. Nitrofurantoin, trimethoprim should be considered. Urine culture should be sent in all cases before antibiotics are started. So this one is not there here, right?
Yes.
Okay.
But in option, the last option was yani, not accurate.
Yeah. So that's why best
Mm.
among the worst. So this one is
Best among these is first.
yeah, oral antibiotics. prefer to give them oral antibiotics for 7 days. NICE advises men who present with symptoms suggest of lower UTI should be treated empirically with oral antibiotics such as trimethoprim, netofenadine, depending on local microbiology protocols. The patient has a dipstick test which is positive for nitrous should be treated for UTI. IV antibiotics are not usually required to treat UTI and infection unless evidence of rigors, chills, vomiting, confusion is there. Therefore, incorrect option. NICE advises the men with UTI should not routinely be referred to urology unless the infection is recurrent. A 2-week pathway should be used if man is more than age 45 and over with unexplained visible hematuria without urinary tract infection or a visible hematuria that persists or recurs after successful treatment of UTI. So, if the patient has an unexplained hematuria without UTI or hematuria that persists after treatment of UTI and age is 45 years and over, you need to refer. If the male is 60 years and over who has unexplained non-visible or visible hematuria, either dysuria or a raised white cell count on blood test, he also should be referred. While excluding a STI infection may be important, this man has symptoms such as UTI and there's nothing noted in history that suggests STI. He should therefore be treated with empirical antibiotics first instance. Antibiotic treatment should not be delayed pending result of urinary microscopic and culture sensitivity, but it's still important to perform this test in order to assess the presence of resistant bacteria. Waiting for culture results would not be appropriate, so this is the wrong answer. Okay, my favorite type of question. Hemoptysis, we have options: lung cancer, pulmonary embolism, Goodpasture syndrome, tuberculosis, aortic regurgitation, mitral stenosis, coccidioidomycosis, aspergilloma, granulomatosis with polyangiitis, and bronchiectasis. 52-year-old old man who was born in India presents with episodic hemoptysis. His only history is tuberculosis is as an adolescent. Chest X-ray showed a rounded opacity, right upper zone surrounded by a rim of air.
Options, doctor.
Options are here. So, hemoptysis, history of tuberculosis, and Gons complex is there, right upper zone. So maybe
Tuberculosis.
tuberculosis again, right?
Yes.
71-year-old woman presents with dyspnea, hemoptysis for past 2 weeks. Clinical examination reveals a loud first heart sound. First heart sound is loud, that is mitral stenosis. A diastolic murmur, mid diastolic murmur, new onset atrial fibrillation, all towards mitral stenosis. Okay, so we have an option mitral stenosis. What do you say, doctors?
Yes.
Okay, dyspnea,
Yes.
hemoptysis is present in mitral stenosis.
लज्जेगा बेटे तुम मजाक समझ रही हो चाक बोल रहे बेटे
Mute, doctor, mute. 62-year-old woman
सॉरी
who is
सॉरी
being investigated for renal impairment presents with hemoptysis. So, renal impairment and hemoptysis. So, renal problem plus lung problem. On examination, she has a flat nose. Flat nose is granulomatosis with polyangiitis. Am I correct, doctor? I was just thinking and remembering.
Yeah.